Hello, this is Alyssa, Critical Care Pharmacy resident, and welcome to my second clinical pearl, which will cover the use of ketamine in the ICU. So ketamine is actually a cousin of PCP or phencyclidine, and I include this from a historical perspective because PCP was originally used in the 1950s as an anesthetic, but because it had such high rates of causing delirium and agitation, it was subsequently withdrawn from clinical use in the 1960s. Ketamine, being a relative of PCP, has the potential to cause similar effects, although to a much lesser extent. And then it still does maintain some of that potential for misuse also. So it's classified as a Schedule 3 controlled substance. So just something to keep in mind if you are handling or administering the medication. Now, ketamine works mainly through binding to the NMDA receptor, and in doing so, it prevents glutamate from binding and inducing excitatory neurotransmission through both sodium and calcium influx. On top of that, though, ketamine probably has other effects, but we don't really understand these alternative mechanisms. In contrast, our traditional sedatives like benzos, including midazolam, propofol, and etomidate, those all act by activating the GABA receptor. So because ketamine works very differently than conventional sedatives, it also has very different and unique pharmacologic effects. And the first thing I want to highlight with regard to this is the dissociative anesthesia. So when we use a medication like propofol to sedate a patient, we're literally telling the brain to shut off. Ketamine works differently in that it's leaving the brain on, but it's simply working by disconnecting the brain from the surrounding environment. So the patient looks like they're awake, but they're unable to interpret what's going on around them. So it's a little bit more like the lights are on, but nobody's home. Ketamine also causes amnesia. It provides pain relief. And then, unlike other sedatives, which tend to cause hypotension, ketamine actually usually provides a small increase in blood pressure and heart rate. However, if you do have a patient who's catecholamine depleted, which might be a patient who's been hypotensive for a really prolonged period of time, then ketamine can actually cause a paradoxical reduction in blood pressure and heart rate. Unlike other sedatives, ketamine preserves respiratory drive, and it can actually improve ventilation because it provides bronchodilation, which is especially important in patients with reactive airway disease. Because of all of ketamine's unique effects, I think it's been studied for just about everything, but for the purpose of this, I'm going to focus on RSI and on analgosedation. So I certainly wouldn't say that we use ketamine routinely for intubation or as a continuous infusion for sedation in the ICU, but there are a couple of circumstances where it seems to fit really nicely. And one of those cases is patients who are hypotensive. Ketamine can help maintain, if not increase, blood pressure, whereas other sedative agents would have a tendency to exacerbate hypotension. So ketamine can work very nicely in shock states. Secondly, ketamine is the only sedative agent that also has analgesic effects. So we get two effects with one drug, and then because of the analgesic effects, ketamine can help us cut down on opioid use, which can in turn help reduce side effects of opioids, especially constipation and ileus. When administering ketamine for an indication like rapid sequence intubation or procedural sedation, we're aiming to achieve that effect of dissociation, and this occurs at high doses. So the mentality here is go big or go home. We're giving a bolus dose of 1 to 2 milligrams per kilogram. Oftentimes, we'll end up rounding this off to 100 milligrams, which will fit for most patients. When given as a bolus, ketamine's onset is within about 30 seconds, and the effect lasts for about 5 to 15 minutes. Ketamine can be given intramuscularly if unable to give IV. When ketamine is used as a continuous infusion for sedation in the ICU, a typical starting rate is about 0.5 to 1 milligrams per kilogram per hour. In contrast, when ketamine is used for pain, the dose tends to be much lower, starting at a dose of 0.05 to zero point 0.1 milligrams per kilogram per hour. So take-home point is that for different indications, ketamine can be used with vastly different doses. When we choose an induction anesthetic for RSI, a couple of key things that we want, first of all, is for the drug to be hemodynamically neutral, and secondly, for it to have a very quick onset as soon as possible. Etamidate's our go-to drug because it fits both of these criteria. It's a sedative hypnotic, it's very short-acting, and it has minimal effect on blood pressure. Midazolam and propofol can be used, although they're not ideal, and then ketamine can also potentially fit here as well. So because etomidate is our gold standard, I wanted to pull out a couple of studies that compared ketamine to etomidate. This study from 2009 is the only study that I'm aware of that did a direct head-to-head comparison as a randomized controlled trial. So in this study, patients were split up to receive either etomidate or ketamine, followed by succinylcholine. They found no difference in intubating conditions. They observed increased risk of adrenal insufficiency with etomidate, which is a known potential side effect, although this didn't translate to any worse outcomes. A few subsequent retrospective studies corroborated the results of that original randomized controlled trial, as they found no difference in the success rate of intubation. King and colleagues found that ketamine was associated with less hypotension following intubation. So again, that's a potential advantage here, although they did not find any difference in clinical outcomes, including mortality. Another area of interest for ketamine is as an adjunct to traditional analgosedation with medications such as fentanyl and propofol in the ICU. So Pryskowski and colleagues conducted a study looking at the addition of ketamine for trauma patients, and they found that ketamine helped reduce both opioid and propofol requirements. However, it did result in an increased need for the use of both Precedex and ziprasidone, which might suggest that these patients either weren't adequately sedated or potentially that they had a higher incidence of delirium. Secondly, Garber and colleagues recently conducted a similar study looking at general ICU patients with addition of ketamine. And similarly to the previous trial, they found that ketamine reduced fentanyl and propofol doses. Ketamine also improved the time spent within the goal RASS range, and they ultimately found no difference in delirium from the time before ketamine was started to after it was initiated. One of the most well-known adverse effects of ketamine is the emergence phenomenon because it can occur in up to 12% of patients. Emergence phenomenon tends to occur as the effect of ketamine is wearing off, and it manifests as delirium, psychosis, or hallucinations. Because of these effects, a lot of providers will stray away from using ketamine, especially if they're not very comfortable with the medication. But key thing to note is that it's fairly easy to manage this emergence phenomenon with the use of a benzodiazepine like midazolam. Some providers will actually order a benzodiazepine at the same time as ketamine to help proactively prevent the emergence phenomenon. Ketamine can also cause muscle rigidity. This can look like seizures, but just be aware that it's likely just a side effect of ketamine. If it is problematic, this side effect can also be treated with a low dose of a benzodiazepine. So in conclusion, ketamine can be a safe and effective alternative to traditional sedatives when used for intubation or for sedation in the ICU. Key monitoring would include keeping an eye out for psychiatric effects such as the emergence reactions and monitoring for delirium, monitoring heart rate, heart rhythm, and then blood pressure, and then apnea, which is mainly a concern in non-intubated patients, especially when ketamine is given as a rapid IV bolus. And that concludes my clinical pearl. If you do have any questions or comments, please send those my way. And thank you for listening.